Hello, everyone, and welcome to today's webinar, Understanding How Breast Anatomy and Milk Flow Dynamics are Impacted by Shield Design Through Ultrasound Imaging. We are thrilled to have you join us. Throughout the presentation, you can submit your text questions to our presenter by typing them in the Questions tab at the bottom right of your toolbar. Feel free to send in your questions anytime. We will collect them and address them during the Q&A session at the end of today's presentation. To maximize your webinar experience, you can participate using other toolbar apps, including handouts and polls. Event handouts, including a certificate of attendance, can be found by clicking on the Handouts section of the toolbar. If you experience any technical issues, please click on the Help button on the lower left of your screen. Please note that today's webinar is being recorded. After the event, you will receive a follow-up email with a link to view the recording. Without further ado, I would like to now introduce today's speaker, Donna Geddes. Professor Donna Geddes, PhD, is globally recognized for her human lactation and breastfeeding research. She is the director of the UWA Center for Human Lactation Research and Translation, ABREST, and the Western Australia Human Milk Bank Biobank. Donna's work is dedicated to addressing challenges in lactation, including the identification of factors contributing to low milk production and the development of diagnostic tools and effective treatments for lactating women. Thank you, Donna, for joining us today.
Thank you so much, Jess, for the kind introduction. We're getting back to basics today. One of my favourite subjects is breast anatomy and milk ejection, and also milk flow dynamics. I think we need a really sound understanding of the anatomy and physiology in order to improve and enhance outcomes for our mothers in terms of milk removal, whether that be breastfeeding or breast expression. First of all, I'd like to acknowledge our funding sources. We receive an unrestricted grant from Medela AG, but we also receive substantial funding from federal sources to carry out our research. We also have generous philanthropic funding for which we are able to create the first national extensive human milk biobank here at UWA in Perth. So when my group looks at the assessment of milk removal of efficacy, which includes efficiency as well as effectiveness, we need to know how much milk is in the breast in terms of how much the baby took, or whether the pump has removed most of the milk. We can use two methods of measuring that, and one of them is volume. You can see the volume of milk here pumped into a bottle. Reading that volume off a bottle is tricky and can be over or underestimated very easily. A way around that is to measure the bottle before and after the milk is pumped, and the difference in grams is equivalent to mils. So 1 gram is essentially roughly 1 mil of milk. In our group, we actually use something called percent available milk removed, and I'll show you why, because volume can be quite misleading. So here we send our mothers home with sensitive scales to weigh the baby or expressed milk before and after every feed or expression. And that usually goes actually for more like 28 hours. The mothers collect a small milk sample before and after each feed and expression, and we measure the milk fat in that sample that you can see that I'm pointing to here. These are small hematocrit tubes. The lower the fat level, the fuller the breast. So we can see very clearly here that this breast is quite full. As the mother empties the breast, the higher the cream content, the more empty the breast, so the more effective the milk removal session has been. And in this case, it's been quite successful, just looking at that. Now, the reason we do this is because we may have a mother here that has pumped 25 mils and another mother who has also pumped 25 mils. From our calculations of the 24-hour data, however, we estimate that this mother only had 50 mils in her breast to begin with. So she has removed 50% of the available milk. However, this mother had a fuller breast and had 100 mils in her breast. So she removed 25% of the milk that was in the breast. Hence, our mother with the lower volumes was much more effective at removing milk than our mother with the higher volumes in her breast. I need to not remind you that all breasts are not the same, either on the outside or the inside. And really, the outside of the breast does not indicate what the anatomy is like on the inside. So still breast diagrams depict breast anatomy in a way that we don't fully understand, or recent studies have actually redefined this anatomy. So you can see here in a front-on view that there's lots of lobes, 15 to 20, and they're kind of evenly distributed around the breast in a radial fashion. And on a sideways view, you can see that a lot of the glandular tissue and the lobes are focused back in the breast, with main milk ducts draining into one duct that dilates into what was called the lactiferous sinuses, holding supposedly substantial amounts of milk for the baby to remove from the breast. And you can see that this milk duct narrows as it comes to the nipple. However, when I did my ultrasound studies, and we're still doing them today, we found quite a different distribution of ducts and measures and glandular tissue. So you can see here that this is an ultrasound image. I have the transducer here on the mother's skin. The nipple is here. And what the transducer does is it detects an image like a straight down cut, as if I've cut the breast in half and flipped it open. So at the back here is the mother's ribs. So you can see that this milk duct, which is darker in nature, so the black tubular areas are the milk ducts, and the bright areas are the glandular tissue. So we can see this milk duct disobeyed the textbooks and remained a consistent diameter all the way to the nipple where it narrows, and we can see the milk ducts in the nipple here. These two ducts were even more belligerent and just joined just in time to exit into a tiny little duct that then moves into the nipple here. This is a similar image here on a different mother. You can see the nipple here. Note you can't see the milk ducts very well. There's a very short main milk duct that is narrower in diameter as to the more distal duct over here, more proximal duct. So again, disobeyed the textbooks. You can see an early branch heading towards the glandular tissue that does fill the area behind the areola and the nipple. I've outlined the skin here, and you can see that the milk duct is almost directly under the skin here and just a few millimeters from the skin at this point here. So these are areas that are very superficial. Again, this is another mother, and you can see her milk ducts are branching very quickly. Again, a narrower main milk duct to the other milk ducts that are draining into that. Lots of glandular tissue here behind the areola. Again, very superficial under the skin here, a millimeter or two. On average, it is about 4 millimeters if we measure it, so there is some variation between mothers. Now, there's a huge variation in duct size. What we found that they were 2 millimeters on average, and about 9 of them, rather than the textbook saying there's 15 to 20, and it can be as little as 4 main milk ducts in some others. You can see this one is huge. It's 10 times the size of this mother's milk ducts, who are very tiny, barely a millimeter in size. And what we find is these mothers can obviously store much more milk in their ducts compared to these mothers here. What I also found was that the milk ducts were highly compressible. Here is a cross-section of a number of milk ducts. You can see they're very close to the skin again. And if I use the pressure similar to that will obliterate the veins on the back of your hand, I can make most of those ducts disappear. So I can compress them so they're occluded, and I can block milk flow, much the way I can block venous flow in the vein on the back of my hand. Now, I talked a little bit about the distribution of glandular tissue, thinking it's radial, mainly because Sir Astley Cooper in the 1840s depicted this in these beautiful dissections where he laid the milk ducts systems out radially on a stone so the artist could draw them. What we in fact find is that the distribution of glandular tissue is maintained in lactation, similarly to our non-lactating state, where most of that glandular tissue actually resides in the lateral and inferior portion of the breast. You can see here on the ultrasound, the glandular tissue is quite bright, but the adipose tissue in the breast is darker, a darker grey. And I've outlined that and filled it in for you here. So you can see the subcutaneous fat becomes more prevalent and thicker as we move from the nipple out to the areola to the periphery of the breast. And you can see that amongst the glandular tissue, there is quite a bit of adipose tissue. So whilst the textbooks might say that most of the breast becomes glandular tissue and that adipose tissue is necessary for it to develop, we in fact find some women with big breasts, most of their breasts, half of their breasts, up to half of their breasts can be composed of adipose tissue. This will obviously change the dynamics in the way that the breast moves within a shield during pumping, just simply by the nature of the difference of the breast tissue composition in that region. And in that region, there is most of the glandular tissue, so up to about 3/4 is situated actually in that 3 centimetre diameter from the nipple. Just an aside, axillary tails aren't as prominent as we might think they are. I don't see a lot of glandular tissue moving up into the armpit, so if you find lumps and bumps up here, be very wary that they may be lymph nodes rather than an axillary tail or a blocked duct. So we now understand the ductal system as a complex system, much like the roots of the tree, that are very intertwined. They may not be radial in nature. Most of the glandular tissue can be situated in the inferior and lateral portion of the breast. It's also very superficial and compressible. So the older diagrams have now been replaced more accurately with these kind of diagrams here, where we can see lots of glandular tissue behind the nipple and areola, complex branching ductal systems, and certainly not really any reservoirs that we thought were there behind the nipple in order for the baby to strip the milk from the breast, because we know that the baby indeed uses vacuum to remove milk from the breast. So how does breast anatomy, how does this knowledge affect what we understand about milk removal? Well, in one of our pumping studies, we found that before milk ejection, which is critical for effective milk removal, on average, mothers will only remove a couple of mils of milk, about half a teaspoon. But if we look at their anatomy, the mothers that are unable to remove milk, for example, if they're hand expressing, are likely to be these mothers whose milk ducts are so small, just a millimetre in diameter, that there isn't really much milk to remove at all prior to milk ejection. And then the mothers with these really big ducts that are much greater, well over a centimetre, are the ones that can express up to 30 or 40 mils prior to even letting down. So there's vast differences even in just this portion of the milk removal session. How does milk duct anatomy impact milk removal via milk ejection? This is me scanning this wonderful mother, looking at the milk ducts on ultrasound. What we found in these studies was that the mothers with smaller milk diameters, remember these 1 or 2 millimetres, had shorter milk ejections and less milk was expressed during that milk ejection. In contrast to our mothers that had greater duct diameters and larger expansions of their diameters at milk ejection, they were able to remove much more milk during the milk ejection. So milk ejection, as I said, is critical, that stimulation of the nipple and areola that sends neural impulses to the hypothalamus to initiate the posterior pituitary gland to release oxytocin into the circulation, bind to the myoepithelial cells surrounding the alveoli that are full of milk, contracting and forcing that milk towards the nipple for the baby to remove, or in the case of a breast pump, to be expressed. We can see here with this mother, she has a huge dilation in her milk ducts. You can see them expanding. You can see the milk moving quite quickly towards the nipple. And those are all those flecks there as well. That's probably the fat globules. So she's able to remove potentially quite a lot of milk in her during her milk ejection. If we look at this mother, we see a similar thing with quite a large dilation of the milk ducts. Sorry, this one here, we can see a large dilation of the milk ducts. It's quite close to the skin again. If we don't remove the milk, you can see the milk going up towards the nipple and then coming back, making its way down to a different lobe. So we get refilling of the breast and redistribution of the milk if we don't remove it from the breast during milk ejection. This mother has small milk ducts. You can see very clearly here that they're much smaller. You'll be able to see the milk start to flow. It seems a little slower. It's much brighter, so it's likely got more fat in it. We have a very small dilation of the ducts. Hence, this mother's anatomy and her milk ejection means she's likely to express less milk than the other mothers that you've seen during the milk ejection. Now, what about the nipple? I often call the nipple the gatekeeper. It keeps the milk in during milk ejection if the baby is not creating a vacuum to remove it. So this is the nipple here, and we have no vacuum on the nipple. This is the breast at this side here, and you can see here the milk ducts are very, very fine, and they're coming into the nipple here, and you can just see them coming through the nipple there. They're barely perceptible. At milk ejection, you can see that the ducts increase dramatically here in the breast, and we have dilation of the nipple ducts, but they're not very large. They're still very, very small in the realms of 1 millimetre or so that you can see here. Now, if you have large nipple ducts, as we can see here, or small ones, this may dictate whether you tend to jet milk at milk ejection in the absence of a baby or a pump. So we call this the non-squirter, who keeps the milk in, and the squirter with the big ducts, who tends to jet when she lets down. We need to reconsider naming things an overactive milk ejection reflex, or that this mother may just have a high supply, because we have seen in the past that downregulating supply has not been had a positive influence on some of our mothers. The fact they jet may just be due to the fullness of the breast and a combination of her nipple anatomy. So what happens during pumping? Well, here I have the transducer sitting on top of the tunnel of the shield. And you can see that it comes round here, and the nipple in the center is this gray heterogeneous area. You can just make out some of the milk ducts here. When the mother lets down, to my surprise, there was quite a large dilation of these ducts, sometimes as large as what we see in the breast. So you can see that the same thing is happening in the nipple as the breast, as we elongate the nipple and apply vacuum, let down results in a large dilation. In fact, if we fit that tunnel to the nipple and look at milk ejection, and as soon as that occurs, we stop and we use a bigger tunnel to leave some room for movement and expansion, and apply the vacuum until milk ejection occurs, you can see there's a massive difference in the dilation of these ducts in the nipple. And in fact, that's to the tune, if we look at one duct, of a 35% reduction by making that tunnel a bit too tight. So let's go back to the anatomy and look at the pain points or points where we might restrict milk flow during pumping. You can see this beautiful diagram from Jennifer Rusby, who is a breast surgeon. She's painstakingly outlined the ducts in the breast, as you can see here, that are narrowing at the waist of the nipple here. So she calls this the waist because it's a narrowing, and then the milk ducts course into the nipple, and you can see they're all concertinaed up like a piano accordion. And then we have distally, as we're heading towards the tip of the nipple, very narrow ducts to restrict flow and keep the milk in. So as the nipple is contracted, we can see these all bunch up, and they provide resistance to the flow through the nipple, much like it is slowing the car down that's driving down a windy road, as opposed to a car that might be driving down a straight road. So if we turn this sideways so that it's as we look at the nipple, so I like to turn my maps around as well, we can see that points of where problems might occur are the waist of the nipple, the concertinaed part here, and the tip of the nipple. So schematically, if we provide compression at the waist, we can restrict milk flow because we're not allowing this area to expand. We need to elongate the nipple to stretch the road out to make it a nice smooth tube for milk to flow fast while milk ejection is happening. And then we also need to overcome this narrowness at the tip with vacuum to enable milk to flow. You can see a nice diagram here actually of the concertinaed up duct, and when it's not concertinaed, you can see it's nice and smooth, so it's not going to provide resistance to flow. We also need to make sure we leave room for the milk nipple to expand, so that those milk ducts within the nipple also expand at milk ejection. So this is where we talk about the waist of the shield, where there is a potential pain point where we might be restricting flow. And obviously this is a comfort thing as well. If we look on ultrasound, you can see easily here is the nipple, these massive expansion of the ducts, and we really don't want compression happening at this point at all to minimize flow. Now, the baby does a similar thing. If we look back to basic principles, the baby attaches to the breast, taking in some of the breast tissue. It elongates the nipple. And as it compresses the nipple here, so you can see the nipple here, transduces here. This is the tongue. This is the hard palate, and this is the soft palate. So again, I'm cutting the baby's base and skull right down the middle and flipping it open like that apple. As I said, you can see the nipple. When it's compressed, it shuts the milk ducts down that you can see in the nipple here, these black areas. As the baby drops the tongue and applies a vacuum, it expands the nipple and these ducts open up. And when the tongue comes down, the nipple expands, ducts open up, vacuum's applied, we can see milk flowing here, right? So the milk flows into the oral cavity, and as the baby reduces vacuum, it compresses the milk ducts, reduces vacuum, and the milk slides under the soft palate here. So essentially the same principles are prevalent in the baby as we think about milk expression. So just to restate that, the baby draws the breast nipple into the mouth, elongating the nipple, draws the tongue down, expands nipple diameter to open the ducts, creates vacuum to cause milk flow, and there is actually minimal movement of the nipple as well. So we never see a lot of movement in most babies. So the anatomical and physiological changes required to remove milk involve elongation of the nipple and expansion of the nipple so we can clear the rows, make them good and smooth. We use vacuum. We use a maximum comfortable vacuum. We know that it improves milk removal, but we must have comfort. And we know that the anatomy of milk ejection affects milk removal and the volumes, and we need minimal compression happening during this time. So if we look at the big hitters, strong vacuum does correlate with increased volumes. So in our study, where we looked at women and applied different vacuums, here is the first bar on the Symphony pump. Here is 125 millimeters of mercury. Here is the maximum comfortable vacuum. So it was turned up until the mother found it uncomfortable and turned back down until she was comfortable. And then we also tested 75% of that vacuum. And you can see there's increasing volumes removed, and it's quite significant with 100% vacuum, which is maximum comfortable. But remember, I also told you about PAMA, or percent available milk removed. And you can see that upward trend as well. So getting greater effectiveness of milk removal using maximum comfortable vacuum. So how does changing shield size or shield diameter impact vacuum? We can see in this very large group of women, we've divided them into fitted appropriately, and by that I mean 4 millimeters more than the diameter of the nipple, about 2 millimeters either side. Fitted non-appropriately, so less than 4 millimeters. Fitted too big, so way more than 4 millimeters. And fitted too small, which is to the nipple or less. You can see none of the milk ejection measures that we look at or comfort was any different between these shields, but we did see a decrease in the strength of vacuum when the shield was fitted what we call too small at this time. So remember, if you have to reduce the vacuum to improve comfort, then it will likely impact efficacy of milk removal. The other thing we have looked at is warmer shields, so warmth. So in light of current practices, some mothers may be putting their shields and bottles in the fridge and then applying that cold shield and bottle to the breast again for a pumping session later in the day. You can see in the red, I've made that red because that's 37 degrees Celsius. You can see that there's much more volume pumped with a warm shield than just room temperature. So we can see increases dramatically in the first 5 minutes, first 2 milk ejections, and up to 10 minutes, and then it plateaus after 10 minutes, the volume. But what about the PAMA in this case? Well, we can see also significant trending upwards of the percent available milk removed, so more effective more quickly than room temperature. So warmth appears to enhance milk removal to some degree. So what about cold? Well, during this study, I placed my ultrasound gel in the freezer and we applied warm gel at 39 degrees Celsius roughly, and the cold gel was really about 19 degrees Celsius. And I used it to look at nipple diameter, and this is with no vacuum. You can see that overall, in all of the mums that we studied, we found almost a decrease by half. So cold will help contract the nipple, reduce the duct diameter, and therefore may very well impact milk flow and milk removal. Now, we're often asked about nipples and how to size the shields from many mums coming into our pumping study recently. So I'd just like to point out, depending on how you measure the nipple, you will get a different result. So we typically measure horizontally across the nipple and vertically up and down from the nipple. And so what you can see here in the circle is that half the mothers have a smaller vertical diameter than horizontal, and half of them have a larger vertical diameter than horizontal. So depending where you measure, you get a difference. And these are the differences here. So you can have a difference between them of up to 4 millimeters, either way, smaller or larger. Then we often have our mothers come in for 2 to 4 sessions. And if we measure on different days, we get different answers. You can see here that we can measure anywhere from 2 to 4 millimeters larger or smaller than the day before. So why might that be? Well, maybe it's the temperature of the room or the humidity, something to do with her environment, what she's wearing, whether she's been leaking from the nipple, but also maybe fullness of the breast. So this needs more work, but certainly brings a level of uncertainty into measures. We use digital calipers, so we get down to 1 decimal place. So what else impacts the percent available milk removed? Well, you can see that the changes to the what we call the 105 shield, so changing that angle at the waist to allow less compression or minimize compression has been carried out, and the studies show that there's a significant increase in percent available milk removed compared to the older shields with the narrower angles at the waist. What's interesting is we've recently tested these more anatomically designed shields with a smoother transition as well that is on the hands-free kit, and we see really good PAMAs, whether we're using them with when we're using them in the studies of around about with the freestyle and the hands-free, 70 to 80% of the milk removed, which is quite a good outcome for expressing. Now, this is some preliminary data that I'm showing you now, where we have had some mothers fitted to the nipple, whatever we might define that as now. So, and then we have 0 to 3 millimeters, 3 to 6, and above 6 millimeters greater than the nipple diameter. And you can look at the volumes, and there is no significant difference here between the volumes removed by a tighter shield versus a larger shield currently. PAMAs, however, are trending to be slightly less with our fitted shield, our 0 millimeter shields, versus ones that give some room to move. However, we do need some more numbers in these studies. Interestingly as well, when we look at the mother's comfort ratings, whilst this is not significantly different, it is trending towards a more uncomfortable feeling for our mothers that were in the 0 category here. In the matched data, I really wanted to show this. This is quite low numbers about how misleading volume could be. So if we have the small fitted shield and ones that are more greater than the nipple diameter in the same mothers, it looks like there's lower volumes, although again, very wide variation and not significantly different. If we go to the percent available milk removed, we can see that, although not different, is trending towards a better outcome for our mums that have room to move. So these are all things we need to consider, how we're measuring, what we're looking at. So really focusing on how the mum feels, what does it look like when you're fitting shields, should really be looking to see what's happening to the areola and the portion of the breast that may be entering the shield or not entering the shield for that matter. And the reason I say that is because we see a number of mothers that come to us and we might use a different shield. And in particular, this mum was having some issues at home. She found that her home pump was more painful, mainly due to the smaller shields, and she was using a balm to effectively lubricate the nipple. In other words, it was quite tight, needing some lubrication. She found after she changed the shields that it took longer to pump with the smaller shield, and a lot of mucking around trying to get that nipple just right, because for her, any slight movement meant she had to stop and readjust because of the comfort. She also minimised her pumping to only 10 minutes, meaning she still felt full and had sore breasts, leading it to pump again sooner and not feeling like she was really getting any downtime for her nipples to rest. She also commented that she thought it was an Olympic sport trying to get sore nipples into a tight shield at 3 a.m. So after switching to the larger shield after she'd come to a session, she just found it was easier. She actually got more milk out, mainly potentially because there was less compression going on, and she could stretch the time out longer between pumps because she could pump a bit longer. And it just felt less stressful and less painful. So I think it's really important that this is individualised to mothers, because as we've seen, anatomy is very individual as well. So the wrap is that breast anatomy impacts milk removal by a breast pump. Milk ejection obviously also facilitates milk removal, so we know stress can impact that, so we want to keep stress at the minimum. Factors that tend to have the most impact on milk removal seem to be maximum comfortable vacuum warmth and shield shape, and shield size is still up in the air as to how much of an impact that has. We must, when we're individually fitting mums, observe what's going on, and we need to understand that we need elongation of the nipple and expansion to accommodate the milk ducts expanding. We need to consider compression points. Where is that transition of the shield and the tunnel? We need to think about shield shape because they vary as well, and look at that tunnel size. But most importantly, comfort is imperative, especially with prolonged use. So thank you for your attention, and I will happily answer some questions.
Thank you so much, Donna, for the presentation today. We're going to go ahead and get started with the Q&A portion. And as a reminder, you can still submit your questions in the questions pane, and we will get through as many as possible. So the first one that we have today, someone asked, is there a relationship between the duct size and the time of the feed?
You mean the duration of the feed, Jess?
It says at the time or end the time of the feed.
Is there a relationship between the duct size and the time, the duration? So in terms of duration of the feed, that's somewhat dictated by the baby in terms of appetite, as well as how the baby's feeling, right? So what we had recently in a live demonstration at our conference last week, we had a baby feed twice before we scanned the baby and test weighed it. And it looked like it was non-nutritive sucking, but on the ultrasound it was removing milk, and it removed 100 mils of milk. So it really is dictated by the baby's appetite, I think. So, and it's a little difficult to tell if they're nutritively or non-nutritively sucking. So it's something we shouldn't worry about with the baby, because the baby, the way it sucks and expands the nipple, it controls milk flow. So it's a bit like a smart milk removal device.
Excellent. Well, thank you so much for answering that question. This next one is, what are some ways to prevent milk reflowing into other milk ducts during the milk ejection, during breastfeeding, pumping, or hand expression?
So it will really happen if we're not removing milk from the breast. So if the vacuum's not strong enough to overcome the end of that, the very narrow part of the nipple. So setting to maximum comfortable vacuum will avoid that. Remember, I was in the side that the mum wasn't pumping. So that would be the main thing. So getting the vacuum set right and the comfort set right for everything to work well. I wouldn't worry too much about it. If it flows back into a more empty lobe, then when oxytocin is released, it will bind to the receptors on the cells around the alveoli more quickly in the fuller parts of the breast. And in the next milk ejection, there'll be a stronger force applied to move that milk forward. So I wouldn't worry too much about that. That would be covered under your warmth, comfort, and vacuum settings.
Wonderful. Thank you. Our next question, someone says that they've seen some advice to change shield size partway through the pumping session to get higher yields. Do you have any comment on this? They're unsure if it's going bigger or smaller.
It's a tricky one, right? So what we do know is that halfway through the pumping session, if it's about 5 minutes, those first 2 milk ejections have the strongest positive pressure. So on average, we will get 70% of the milk that the mother is going to remove, all going well, in those first 2 milk ejections. So changing shields doesn't really make sense unless it's too tight. So we've restricted in some way the flow in the first 5 minutes or so. So that would mean that we'd remove less milk and there'd be more milk in the breast. So also it may be that I'm not sure if it's going up or down with these recommendations, but yeah, I think it may be due to the mum's anatomy, right? So how much of the breast is going into the tunnel and where that angle of compression is.
Great, thank you. Our next one, someone asks, are you including plastic shields and flanges, or have there been comparisons with silicone flanges?
So currently, we are due to the issues with nipple diameter and this moving target of how you actually fit a nipple, a breast shield. We're experimenting with. We've been using hard shields so far, the data that you've seen, but we've also been looking at some silicone inserts. Mothers find those comfortable, but I can't really tell you yet how they perform, mainly because of the volume issue being a bit not so accurate as PAMA. So we would like to do PAMAs on those. And you can see in other cases, some mothers might get more volume and others get less. But we don't know how much milk was in the breast to begin with. So much like that example I gave you at the beginning.
Okay. Our next question is, someone asked, do you have a recommended method for warming a breast shield?
Oh, I just recommend not having it really cold, or mothers, maybe having to wait till it warms up. I don't actually. That older study, we'd used like a water jacket on the shield to warm it up. But what will happen is it'll eventually come to room temperature or to skin temperature after a while, but it probably reduces efficacy in terms of how long the mother needs to pump if it has an effect.
Okay. Our next question, someone asks if you have a recommended amount of time a mother should pump for a session.
Oh, I recommend it. So I could bore you with a lot of ratios and milk flow studies that we do where we try and figure that out. So it is individualized in some ways. Many women have continuous milk ejections. In other words, they have about 4 milk ejections. So milk flows quickly and reduces, flows quickly and reduces. And many of those mothers could stop pumping in 11, 12 minutes. And so I think for mothers, they really have to observe what's going on with their individualized flow pattern. And lots of mothers, or not lots of mothers, maybe 20% of mothers, we see what we call a late milk ejection. So you might be pumping and there's no milk for 2 or 3 minutes, and then you have this late milk ejection. In most mothers, that's not a lot of milk. That's just a few mils or, 4 or 5 mils in terms of the amount they've pumped. So it really depends on if the mother wants to, have a quick pumping session. Pumping for another 5 minutes may not give her a lot of return for that time. But in other mothers where the milk, she has a big supply and the breast is really full and she's having lots of milk ejections, she may go for longer. So in a short story, most women could stop around 11, 12 minutes. But with others, depending on their supply and their flow rates, they might want to go longer.
Okay. Great. Such good questions coming in. Thank you, everybody. The next one is, when talking about flanges, is it better to size up or size down?
Oh, that's a good question. So room to move is kind of my tagline right now. So you saw in our case study, and we're getting reports of too tight, which might be due just simply to the measurement on the day or that particular day, is likely to have more negative consequences than allowing 2 to 3 millimeters room, or 2 to 4 millimeters room for things to move. So, yeah, I think based on the anatomy and what you've seen today, a little room to move is not too harmful.
Excellent. Someone asks now if there's a difference between the right and the left breast as far as the ducts.
As far as the ducts, they're fairly similar from the early studies in number and size. You see the mother with the big ducts, all of their ducts tend to be bigger. So they're probably the women that people aspire to be like, but it's really their ductal anatomy that's allowing them to empty the breast really quickly. So if you've got really small ducts on one side, you've got small ducts on the other side. So it tends to be like that. Milk productions can differ by 70 mils or so, or sometimes more. That's more to do with the glandular tissue and the volume rather than the number of ducts and the size.
Wonderful. Someone else asks, do the duct sizes change with the stages of lactation? So do women that have larger ducts keep them larger, or does this change as the baby grows?
We don't see much change at all in the first, when we're in established lactation and milk production is consistently the same, usually all the way through that kind of 1 to 6 month mark. We don't see any changes in duct dilation. Where we might see it is if the breast is really empty and the women are weaning. So you might see less of a dilation just simply because milk production is halved. So we see that mothers drop to around 400 mils as they're weaning. So this is more of a milk ejection, milk flow kind of thing going on. And early on, we see that it's a volume thing as well. So not so much the ducts changing in response, but the amount of milk and the flow changing due to that.
Wonderful. So there's been several questions that ask about, do you have a specific tool that you recommend for measuring nipple size to determine the flange size?
Okay, so when you see us do this, we did this live again. We did a pumping session live on Thursday for our conference. What we usually do, I'll tell you in the research, is we look very closely at the nipple to determine the base. So you really have to get in there and have a good look as to where the more dense muscular tissue is and where that ends. So not just looking at areolar changes in colour. And then we mark that and then we measure it with digital calipers. So in terms of a tool, probably a circular tool is a good idea because it accommodates the fact that the vertical diameter might be greater. So currently we're fitting to the largest diameter. So remember, half of the mothers will have a smaller horizontal diameter if you're using a horizontal. So it's about how you use that tool to get the best fit, probably.
Wonderful. These are such great questions coming in. Let's see where our last one was. Someone asked if you could clarify that you mentioned adding 4 millimeters to the tip of the nipple measurement to determine the breast shield size, taking into account the other factors.
Actually, I'll just clarify that the tip of the nipple is narrower than the base. So we always measure the base of the nipple. And I should have probably said that. Remember, that's a pain point. That's where the compression can happen, where we get that massive dilation in the breast. So we add, because we've above those images I've shown you where we can show we can restrict that by being too tight, we add 2 millimeters to the widest diameter at the base of the nipple. Because the other issue is, where do you measure? As a scientist, where do I measure the tip of the nipple? If it's a curved, it's even harder to measure that as it's tapering. So yeah, we try and standardize. And given that the tip of the nipple is often, not always, but often smaller, we would say, then you are potentially restricting even more the base of the nipple. If that makes sense.
Thank you. So we do have time for just a couple more questions. One of them, someone asks, you mentioned about the amount of breast tissue that's being pulled into this shield tunnel. What is the recommended amount of tissue that should be in the shield tunnel?
Oh, that's a really tricky question. That's really hard because at the moment you can't see inside. I think, this is why fitting and watching pumping, so that you need to do a little bit of what the baby's doing. So it's anchoring, it anchors and elongates the nipple, and then it moves not too much. So the same goes for pumping. We don't generally want to see the breast moving in and out a lot. So it'll be governed by the pliability of her tissue, and we get stretchy nipples sometimes. So that is, why many protocols say you can start with something, but you really must watch it. And then it's a little difficult when you're fitting if you're removing milk, because you might get a size, you mess around with the sizes, but you've already removed half of the milk. So you might be misled by a size later in the session because there's less milk there to remove already. So not a straightforward answer, but I think many clinicians probably will recognise very quickly when things are stuck, as opposed to moving smoothly.
Okay, thank you. So we're down to our last few questions and our last few minutes of the webinar. Someone asks, for fitting mothers in the hospital, should they lean towards a larger shield size?
I guess room to move is the thing I keep saying. If things are not moving and they're, stuck, and the nipple's being pulled, or is rubbing a lot, with constant use, you run the risk of, doing some harm in terms of our mother who is experiencing a lot of pain and needing to use lubrication, which is another step that mothers need to do every time they pump if they're predominantly pumping. So I think, 2 to 4 millimeters gives you room to move as a starting point, and then definitely revisiting that. Actually, if you're in the hospital, mum's sensitivity can change. We know that increases in the first 4 days after birth, and then it plateaus. So revisiting that, not just saying this is set in stone in terms of the mother's comfort as well. And we've also seen mothers be able to use higher vacuums as their lactation and their milk comes in and their lactation progresses. So it's highly conceivable that things can change after a week or 2.
Great, thank you. Someone asks about, before coming into the study, were your participants already pumping? So were you potentially correcting their flange size, or were they not using flanges previously?
So for all of our studies, we now ask what flange size they're using, but we have a standardized protocol, which is the 4 millimeters. So if that's that's how we're doing it now. So if they're basically whichever diameter is the largest to allow a room to move. It's becoming increasingly prevalent that a lot of women are using smaller sizes. So we're still designing the studies. The studies you've seen show that if we split things up by a few millimeters, we get no differences. So then it all boils down to comfort. So yeah, we really get feedback from the mothers. So some mothers might change their shields based on the experience they've had with us to different diameters, but that's usually up to them.
Okay, great. So we have just one last question and then we'll close for the session. Someone asks if there's any truth to the size of the breast shield being too small if the milk expressed is foamy or bubbly.
Oh, foamy or bubbly probably indicates a different issue with the pump rather than shield size. So somehow air is getting in there. We don't see air in the breast at all. So it might be fitting connections to that shield. I would be moving in that direction, checking out the pump, making sure it's all working correctly, or trying a different kit or pump to test whether that foamy milk is actually due to the pump rather than the shield.
Wonderful. Thank you. So thank you so much, Donna, for the presentation today and for joining us for the Q&A session, and for everybody for attending today's webinar, Understanding How Breast Anatomy and Milk Flow Dynamics Are Impacted by Shield Design Through Ultrasound Imaging. So once we leave today's webinar, you're going to be redirected to a survey about today's webinar, and we really appreciate if you could just take a few minutes to complete it, as we really value your feedback. You'll also receive a link to view today's webinar recording in the follow-up email that you'll receive. So on behalf of Medila's Medical Affairs team and our presenter, thank you so much for joining us and have a great rest of your day.
Thank you.